In the last part of the series, we will discuss on weaning from ventilation. Here, we will discuss the definition and process of weaning, the concept of ventilator dependence, how to assess readiness to weaning, spontaneous breathing trial, and certain predictive indices that help in weaning from ventilation. Weaning is the process of liberating the patient abruptly or gradually from mechanical support once the primary cause of respiratory failure is reversed. 75% of the patients can be easily weaned by a simple process. 10 to 15% may require a weaning protocol over 24 to 72 hours. 5 to 10% of them may require gradual weaning over a longer period, and 1% may get chronically dependent on mechanical ventilation. Any critically ill patient who gets intubated for respiratory failure has to be treated with mechanical ventilation for the same. Once there is clinical improvement in the lung condition, early suspicion for weaning is the key. This is followed by a spontaneous breathing trial to assess readiness of weaning and extubation. If successful, the patient can get extubated. However, a certain proportion of patients may get re-intubated who needs reassessment of factors for failure of extubation. We find that suspicion is the key to early weaning. It is estimated that the time spent in weaning process accounts for 40 to 50% of duration of ventilation. This may lead to unnecessary patient discomfort, increased complications in the form of ventilator-associated events, and increased cost of care. The incidence of unplanned extubation is estimated to be 0.3 to 16%. Of these, 85% is patient-initiated and 15% is accidental. A key finding to note is 50% of these with self-extubations during weaning process do not require re-intubation, suggesting that we may be overdoing ventilation in whom it may not be necessary. Premature weaning is equally dangerous as failed extubations have been found to have higher odds of death and infection. Ventilator dependence can be understood by the relation between load and capacity. Load denotes the workload on the respiratory muscles, and capacity is the effort needed to overcome the load. If the patient's capacity to overcome a load is very less, then the patient becomes totally dependent on mechanical support. As the condition improves, the load reduces and the capacity improves. That is, when the disease process improves, spontaneous breathing can be initiated. When the load is completely reduced, then the patient may not require mechanical support and may breathe spontaneously on his own. Respiratory load is increased in conditions that reduce lung compliance as pneumonia, pulmonary edema, fibrosis or hemorrhage, or in conditions which increase resistance as airway bronchoconstriction, conditions where there is inappropriate ventilator setting such as an inappropriate PEEP, rate, or if there is significant patient-ventilator asynchrony, and in post-extubation cases when there is significant amount of glottic edema leading on to airway narrowing. The common non-respiratory causes include cardiac dysfunction, increased metabolic demand, unresolved sepsis, and neuromuscular causes such as a depressed central drive secondary to sedatives or the primary neurological condition, or peripheral neuromuscular weaknesses or critical illness neuromyopathy. Metabolic factors like poor nutrition, hyperglycemia, anemia, and ventilator-induced diaphragmatic dysfunction as well. The key factors that determine readiness to wean include improvement of respiratory failure, patient's ability to maintain adequate oxygenation, adequate ventilation, and absence of major organ system failure. Apart from this, after weaning, if the patient needs to be extubated, an intact airway protective mechanism is needed. Adequacy of oxygenation can be defined as a PaO2 of more than 60 mm of mercury at an FiO2 of less than 40% and peak requirement of less than or equal to 5 centimeters of water. Adequate ventilation is defined by an intact ventilatory drive, age-appropriate respiratory rate, and a minute ventilation that is capable of maintaining PaCO2 in a normal range with minimal dead space ventilation. Finally, other organ dysfunctions, nutrition, and electrolyte status need to be optimized for weaning. As the patient's lung condition is improving and is able to oxygenate and ventilate better, the pressures can be reduced gradually based on the requirement. Once minimal pressure supports are reached, then the patient can be subjected to spontaneous breathing trial. This is a test to determine the readiness to breathe without ventilator. It can be done using a pressure support or a CPAP or a T-piece. Here, the patient is subjected to one of the above modes for a period of 30 to 120 minutes, and if tolerated, the patient can be extubated. Weaning process can be classified as simple, difficult, or prolonged weaning based on SBT and on the duration of weaning. It can be simple if the patient is successfully extubated on the first attempt without any difficulty. It is considered as difficult if they require up to 3 SBTs or as long as 7 days from first SBT to get extubated. It is considered as prolonged if there are more than 3 SBT attempts which are failed or if they require more than 7 days of weaning after the first SBT trial. Weaning is considered successful if the patient gets extubated and does not require ventilator support 48 hours following the extubation. Weaning failure is defined as either a failed SBT or if the patient gets extubated and then re-intubated or there is need for resumption of ventilator support within 48 hours of successful extubation or when there is death within 48 hours following extubation. SBT failure can be defined by objective and subjective criteria. The objective criteria include tachypnea, tachycardia, hypertension or hypotension or occurrence of arrhythmias, hypoxemia and acidosis due to ventilation failure. The subjective criteria include diaphoresis, increased efforts, agitation and anxiety. It is always better not to wean the patient to exhaustion during SBT trial. The presence of anxiety, diaphoresis, tachycardia, tachypnea, and desaturation are ominous signs that are better avoided during SBT. In any patient who fails SBT, we need to review the possible reversible etiologies for failure. If any, we need to tackle them and SBT is to be repeated daily. Daily sedation interruption has been associated with decreased ventilation days and shorter ICU stay. The presence of a multidisciplinary team with protocolized weaning also has been found to have reduced the weaning duration. There are several predictive indices that are used to determine failure of ventilation liberation. Different studies use different cutoffs, which makes applicability of these predictive indices difficult at the bedside. The indices could be ranging from simple ventilator parameters like respiratory rate, tidal volume, forced vital capacity, or minute ventilation. Rapid shallow breathing index is a common index used at the bedside which is given by respiratory rate upon tidal volume. A RSBI or Tobin index, if it is less than 105 breaths per minute per liter, has good predictive index for weaning success. There are also indices that predict the central respiratory drive such as airway pressure developed at 0.1 seconds after the beginning of inspiration against an occluded airway, and also to determine the respiratory muscle strength such as maximum inspiratory and maximum expiratory pressures. Volumetric capnography, which plots the carbon dioxide concentration in the airway gas against the expiratory volume, can also be used to determine success of weaning. The slope of an expired single-breath carbon dioxide waveform determines the physiological dead space. It is found that if the dead space ratio is less than 0.5, it can reliably predict extubation success up to 96%. If the ratio is more than 0.65, the chance of extubation success drops to less than 20%. It is important to remember that all parameters need to be considered together while predicting weaning. A single index will not predict success or failure reliably. Also, these parameters consider lung function as the key component and do not take into account organ dysfunction or nutritional status of the patient. Evidence is still limited in pediatric population. In brief, any patient who is on mechanical ventilation, if the disease process has improved and is able to maintain his oxygenation and ventilation adequately on minimal mechanical ventilation settings, one may use one of the predictive indices and determine if the patient is suitable for weaning. Say RSBI if it is more than 105, which suggests high chance of weaning failure, then we give rest to the patient, go back to the same settings and reassess after 24 hours. If the predictive indices are favorable, then the patient undergoes spontaneous breathing trial. This can be done for a period of 30 minutes to 120 minutes under low-level CPAP or low-level pressure support or a T-piece breathing. If the patient passes this test and has intact airway reflexes, he can be extubated. If the patient fails the spontaneous breathing trial, we need to reassess the factors for failure, provide him stable support for another 24 hours before resubjecting him to spontaneous breathing trial. In summary, assessing readiness to wean is a key step in managing ventilated patients. Weaning can be simple, difficult, or prolonged. Use of predictive indices can help reduce the rates of reintubation and extubation success. If you like these videos, please subscribe to Little Criticos for more updates.